at Lycos, and I've done some consulting for Mosaic on psychedelic related content. I have the following learning objectives, which you have too. And I want to start by putting the research, this contemporary research, into practice, because into context rather, because some of the earliest research with classic psychedelics in the Western world was studying their effect in patients with alcohol use disorder, so back then called alcoholism. And most of those studies were looking at the use of LSD, so not psilocybin like we're using today. And, as is the case with most studies that were done during that time, the methodology really wasn't what we would expect today if we're interested in FDA approval. The controls weren't good, and some of the studies had extensive psychotherapy, while others had virtually no psychotherapy at all. So as you know, most of the research in the US ended with the passage of the Controlled Substance Act of 1970, and that the Renaissance in the US really started again in the 1990s. And the reason that folks got interested in studying LSD for alcohol use disorder is that the original researchers had noticed how when some alcoholics experienced delirium tremens, which is a very severe alcohol withdrawal syndrome, in which a person can, among other things, hallucinate, many folks who went through DTs, as we call them, stayed sober, like they'd been, the term that they used was scared sober by the experience of DTs. And at that early time, LSD was thought of as a psychotomimetic. So the idea was that these researchers were going to try to use LSD to artificially induce a terrifying experience that would scare them sober the way that DTs seemed to do. But then when they started doing that research, they actually found something quite different. And that was that they tended much more frequently to have an experience that was consistent with psychological frameworks that saw alcoholism as a spiritual deficit of some kind. So Carl Jung, for example, famously said, "Spiritus contra spiritum," meaning spirit, as in spirituality, against spirits, as in alcohol. And then William James likewise said that the only cure for dipsomania, which means drinking a lot, is religion. The Oxford Group was a Christian organization that wasn't actually addiction focused, but felt that many things in life, virtually all things in life, have a spiritual solution, including alcoholism. And they had a spiritually oriented group program to support that. And that one of the members of the Oxford Group became sober through a process of spiritual conversion coupled with group support. And that person inspired Bill Wilson, who was one of the founders of AA, Alcoholics Anonymous, to do the same, to get sober. And then Bill Wilson, in turn, saw a spiritual awakening as the crucial first step in what developed into a 12-step recovery process. So there is a history of linking powerful spiritual experiences with sobriety. And there is a history of hypotheses that then started to emerge in the LSD world. So the psychedelic model, as we hear it described, is one in which someone gets a single overwhelming dose of a classic psychedelic. And that model was favored because the goal, given sort of how these hypotheses were generated, the goal was to induce a spiritual experience and to occasion the kind of conversion experience that we would expect, that would set people on a different path, that would get them to stop drinking the way that the mentor of Bill Wilson did. So lower psycholytic doses that you may have heard of wouldn't be expected to do that. So the idea was spiritus contra spiritum, and that you'd induce a spiritual experience so that they would quit drinking. Not that you would scare them sober, but you'd kind of smack them over the head with God, and that would give them new meaning and purpose. Um, Again, those early data didn't come from studies that were particularly well controlled, but a contemporary meta-analysis looking at data from clinical studies in the 1960s wanted to see if if there were positive findings when all of the numbers were pooled. These were almost all male inpatients who had almost all had just a single session of LSD. So remember, a single overwhelming dose is what they'd been going for at that point. They've been using doses between 210 and 800 micrograms. 800 micrograms is an enormous dose of LSD. There were varying control conditions and major variation across the studies in the level and content of the preparation, support, and integration therapy, the psychosocial platform. But nevertheless, they still found, this is Krebs and Johansson, still found that the overall odds ratio favored LSD in these very, heterogeneous studies. So that kind of wasn't the cause for, but was in alignment with a pilot study that was going on at the same time. That was led by Michael Bogenschutz, who's at NYU with me right now, who led at the University of New Mexico a study of psilocybin-assisted treatment for alcohol dependence. So this was a small proof of concept study. It was open label, just 10 participants. All of them got 2 doses of psilocybin as well as 12 therapy sessions. Single group, like I said, and they found that so here is the baseline, and here is, right before the first dosing session. And so this slope you can think of as being the result of kind of placebo plus the psychotherapy. And then there's a pretty dramatic drop. And these, the 2 lines are the percentage of drinking days and the percentage of heavy drinking days. So here's the first psilocybin session. And the second one was here. I think it's actually here. Following on the heels of that very positive study, but I hope that you've sort of been thinking already and talked to already about how expectancy bias is very, very real. Michael moved to NYU, and his team here conducted a randomized controlled trial of psilocybin for alcohol use disorder that was much larger and again controlled. So this was N of 95. The participants had alcohol dependence. It's worth noting, well, we can talk about this later, that the participants could not have an active, couldn't have active PTSD, couldn't have an active mood episode. So they could have a history of major depressive disorder or a history of PTSD, but couldn't currently meet criteria for PTSD or, a discrete major depressive episode. Psychotropic medications were exclusionary. I highlight these things because usually the folks who are seeking treatment for alcohol use disorder, this isn't the case for them. And so when we think about generalizability, it's always important to be thinking about that. Similarly, concurrent addiction-focused psychotherapy was exclusionary, but peer support wasn't. And so they were allowed to be in AA, they were allowed to be in Smart Recovery. Similarly to the other, primary outcome was the percent heavy drinking days over the course of a very long period of time, over the course of a 32-week period after dose 1. So a sort of long-term reduction in percent heavy drinking days. They were given 2 doses of psilocybin. The first was 25 milligrams per 70 kilos, and then it was increased depending on the MEQ score, the Mystical Experience Questionnaire score, so the intensity of the spiritual kind of or type of the experience. And the placebo group had Benadryl at escalating doses as the control. Diphenhydramine was the control for that. So the intervention took place over about 2 weeks. Like I said, there were 2 dosing sessions. Each of those is about 8 hours. Each of them had a team of 2 therapists that, each of the participants was working with 2 therapists who were present at virtually all sessions. We tried our hardest to do that. And it was a really integrated approach to psychotherapy. It was one that that took an evidence-based element. We call that motivational enhancement and taking action. So that has as its core motivational interviewing, and then aims to amplify that motivation and then also give them concrete tools for how to better support themselves in their journey. And then also kind of psychedelic specific preparation supported integration. I say psychedelic specific, and that's not quite true, but it was included because this is a psychedelic study, and anytime you're hearing about a study with psychological support, you're talking about some variation on this theme. I will refer to that shorthand as PSI as it's written there. This is a picture of one of our dosing rooms at NYU. So in addition to the therapeutic framework, we're of course also always trying to attend to the environmental aspects of setting. And then here, looking at our primary outcome, you can see that after the, so this again, this is baseline, and then this down here is when they're about to get the first dose of psilocybin. And so it's this differentiation that's actually the one that is most meaningful to us. And you see that there's a distinct separation between the two groups. So everybody responds quite well to the therapy, and that's something that I'm always quite proud of. But they then separate out, even though the therapy is ongoing. They then separate out the psilocybin and the Benadryl groups. And you see that in terms of heavy drinking days, which was the, like I said, the primary outcome of the study. And then you also see it in terms of just the percent drinking days and the drinks per day. So just kind of put it into context here. It's 23% versus 9.7% of folks at the 32-week follow-up that's not true. Sorry. The placebo group had about 23%, and the heavy drinking days, and the psilocybin treated group had about 9.7%. And this is worth noting, if those numbers don't impress you, I think anybody who has a significant alcohol use disorder, like that might be a big change. But we also didn't ask our participants to be sober or to set a goal of sobriety, which is actually kind of unusual in alcohol use disorder trials. And so, so we weren't saying you must get sober, please promise to try in this study. And, that we did that because we really wanted to be aligned with a person-centered approach in which the therapists are not, forcing goals on someone. We're really looking to serve the person in becoming, into developing a life and a lifestyle that's aligned with their values, not our own. And so we're always thinking as therapists about our own value system and how it might interfere with our ability to really serve a participant whose value system might be a bit different. I will say that the kinds of experiences that participants reported were highly variable. So even though psilocybin's effects have often been described as mystical, with features of unity and a noetic quality and sacredness, positive mood, transcendence of time and space, ineffability, in practice, they were extremely variable. So here are some quotes from 3 of our participants who did quite well drinking wise. One of them said, "I'm going to tell you a secret. It's the worst kept secret in the universe because everyone knows it but you. You are a perfect creation of the universe." So that's a little bit, classic what you expect, what people talk about in the news on psilocybin. And then another participant said it was a crash course in dealing with feelings of disappointment, regret, shame, and unworthiness. Someone else said about the peak, "Nothing ever felt worse than those 2 hours." So it really wasn't all transcendence and bliss. It really wasn't all conversion experiences leading to a behavioral change. that being said, many participants did have various kinds of transpersonal experiences. So here are a few quotes from others. One said that she felt she was filled with endless love and acceptance, that she was experiencing a universal power that was always present within her. You know, I think it's important here to note that she encountered only a glimpse, right? Complex, timeless, spaceless power beyond description. But even so, even months later, at the end of the 12-week treatment, she reported a profound reorientation of her life. And that was both spiritually and behaviorally. In a different kind of transpersonal experience, one participant felt she was in contact with her deceased mother and connecting to her maternal lineage. She reported feeling loved by her mother for the first time, which then opened her up to the possibility of greater self-compassion. And she also felt that in connecting to her maternal lineage, she felt connected to creative and spiritual roots that hadn't felt alive to her, but which became really important in the integration process. And I'll say that this was extremely challenging. She was my participant, and it was an extremely challenging experience, sometimes very unpleasant. This was the only participant, for example, that I've ever had to talk down in order to really prevent her from leaving the site during the peak of the experience. So it was incredibly powerful, but it also required quite significant resourcing on the part of both the participant and the two therapists. We did a qualitative study looking at a subset of participants, so 13 participants from the parent trial. So in semi-structured interviews, looking for major themes that emerged from those interviews. And those led to a finding of compassionate self-awareness as a theme in many psilocybin sessions, and greater attachment security. And I'll say that this really wasn't just, sort of psilocybin-assisted therapy led to a development of compassionate self-awareness and greater attachment security. And psilocybin-assisted therapy, I'm not saying it for no reason. It wasn't just about the acute experiences. If you recall, on the primary outcomes data, the placebo group actually did quite well as well, because they were all, I think, getting the therapy. And I think that those experiences that folks on psilocybin had were important, but they and the therapy together really laid the foundation for the development of more adaptive attachment styles and emotion regulation strategies. And then both of those could be, strengthened during the drug-free therapy sessions. So a quick summary: psilocybin-assisted therapy is better than Benadryl-assisted therapy for alcohol use disorder. A broad range of subjective experiences can come up in the dosing sessions. Those might be transpersonal, but maybe not. Relational, enhanced self-compassion, those things matter. It's really not all about euphoria and oceanic boundlessness. And that's important, I think, for participants and patients to know going in as well, because, not just because of expectancy bias, but for expectancy and expectations generally. It's also important to think about how therapists need to be open and flexible around spiritual experiences and themes. So some participants may have zero prior context for spiritual type experiences, which can be confusing in the session and during integration. And so there is this balancing act that you as a therapist have to pull, in which you're able to invite the participant to consider potential contexts, potential languages for these phenomena, while maintaining and modeling beginner's mind, really working to avoid heavy-handed interpretation, which can be hard if you're really excited about how your psychospiritual framework seems to map onto someone's experience and vice versa. It's also really important to think about how doing just that is itself an expression of power. Maintaining beginner's mind is itself an expression of humility. And so I would, of course, invite you to do the latter and not the former, or at least to be mindful of when you might be doing the former. And here too, I emphasize the therapy. What's the intervention? So this was the visual or illustrated abstract in the JAMA Psychiatry paper with the primary outcomes. And you can see here that it says that the intervention was psilocybin or diphenhydramine. And that's actually not true. In this integrated treatment model with all of the elements that I was talking about, we're talking about 31 hours with 2 therapists over the course of the 12 weeks. And that is really significant. It is not often the case that anyone will get, 2 hours a week over 12 weeks with one therapist. And so this is an intensive intervention, and it is one that is, has a psychotherapy platform associated with it. I think that anytime you're caring for folks with alcohol use disorder, it is important to think about trauma and important to remember that many folks who are drawn to psychedelic treatment, even, regardless of what they're looking at for, see in this case, there's problematic substance use, alcohol use, as an effort to self-medicate by numbing painful experiences of trauma, shame, alienation. And I do think that psychedelic treatment is an opportunity to expand consciousness rather than blunt consciousness. And unfortunately, for some, what that might mean is an increased awareness of really deep pain and buried wounds in a way that can be experienced as traumatic if the therapeutic relationship is insufficient, if there isn't a good enough container to hold the participant in their experience. And again, kind of humility and power comes up here as well, because we all know that some people have been harmed by therapists who insist that the expansion of consciousness is a morally good goal. Especially when you're putting it in contrast with alcohol use, say, as a way of blunting consciousness. And yet that too reflects a certain value system. And we have to be really careful about not forcing someone into a state in a way, that's coming from our own value system and not from theirs. So increased awareness actually isn't everyone's choice. And so really thinking about that and what it means for them to lean in to an experience is something that's important for any psychedelic therapist to do. So trauma-informed care, as a related point, is absolutely essential. And that really means that we're centering safety. They have to feel safe enough to take the risk of a psychedelic experience. Trust, mutual trust, humility, our responsiveness, and a real genuine desire to collaborate, to be working together. And also, whether they're having a blissful experience or not, like I had a participant for a different study recently who had a 3.5-hour orgasm experience. Like, we have to be able to hold very intense emotions with and for the participants. And we also really have to be able to let go of those intense experiences when the time comes. Otherwise, we are causing harm to ourselves, which is also unethical and has repercussions down the line for others as well. When we think about being good providers of care, we also, of course, have to think about who's receiving the care, particularly in these psychedelic clinical trials. And I would say there's, a prominent lack of diversity among participants and therapists and research. And that's also true in a lot of other psychedelic research. But the MDMA efforts really have outpaced the psilocybin world in terms of getting better equity here. What are some of the reasons? There's no funding for community outreach efforts that might increase recruitment of participants of color, other marginalized populations. There might be institutional barriers to bringing in outside therapists. And yet outside therapists and not people who have come up through the system like me might be necessary to increase diversity in the therapy pairs. So, poor excuses, I would argue. But it is really the shadow of psilocybin research that this, $100,000 was the median household income in our alcohol use disorder study. One of our participants had $4 million So, are those the same people that we're normally treating in an alcohol use disorder trial? I would say generally not. And also the racial ethnic diversity was really poor as well. And so we're thinking about how to work with other populations in a way that can rectify this, because it's a real problem. And it's a real problem not because of scientific validity. Of course, it limits how we interpret the data. Like there's cultural bias, and this is true all the way back to Walter Pankey, who came up with the mystical experience kind of questionnaire, essentially, or at least the 6 features of it. That there's a real cultural bias in how that is characterized. That language might not speak to all people, and when we have a lack of diversity, we really might struggle to know that if everything is aligned with our own cultural experience. Of course, limited generalizability simply by virtue of a lack of diversity in a patient population. That's true of any kind of clinical trial. A lack of diversity among research therapists is important, not just for equity, but also because it can perpetuate inadequate cultural awareness and cultural humility among clinicians who otherwise have high levels of social capital. And so it creates this group of quote unquote experts who are actually ill prepared to meet the needs of a broader population. I think thinking about trauma and the ways in which the power dynamics in the sort of triad, the 2 therapists and the participant, thinking about how those power dynamics are alive, certainly even before there's a racial or cultural disparity, and how is it difficult or more difficult to minimize the power differential when race, culture are not being addressed. And social support is really important in substance use disorder treatment. And so thinking about how, what kinds of cultural support outside the psilocybin experience and outside the study they have access to can certainly change the generalizability of the results. I also think that a lack of diversity matters for each of us, not just scientifically, not even just clinically, but in terms of personal and social/societal integrity. And I think that that's because, or the way I think about it is that it reflects and perpetuates a major failure to recognize and to correct both implicit and explicit bias. And that is antithetical to these psychedelic values, we might say, of interconnectedness, abundance, communitas. Timothy Leary said, set and suggestive contexts account for 99% of the specific response to the drug. Thus, you cannot sensibly talk about the effects of psilocybin. It's always the set and suggestive context triggered off by the drug. Thinking again about power and privilege, they're especially important when we're thinking about increased suggestibility, right? What Stan Groff described as non-specific amplifiers of classic psychedelics can absolutely amplify the power differentials between the therapists and the participants. And those disparities in social location may affect the content, thinking about Timothy Leary's quote, and the quality of psychedelic experiences. Again, trauma, and thinking about the ways in which power differentials at all, but particularly enhanced in the setting of increased suggestibility from psychedelics, can be dramatically important when working with folks with trauma. And, mismatches and even unconscious therapeutic or empathic ruptures may affect the success of integration efforts and can also directly or indirectly cause harm. So, mismatches between cultural, racial, social location, other elements of social location, can, gender, sexuality, all of these things can create or present an additional barrier. And in doing so, can limit the success of integration efforts. And the psychedelic experience is really only as valuable, it seems, at least at this point, no one's proven otherwise, but is really only as valuable as the integration. That's really what the integration means, the coming into a new kind of wholeness through that psychedelic experience and the processing of it. So always, 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 it's important for therapists to be thinking about, what are we suggesting when the patient is in a suggestible state, right? And even if you think you're not suggesting anything, even if you think you are the most non-directive person in the world, it's important to know that all psychotherapies are values-based. So to be asking yourself, how aware are you of your values, of how you root yourself in kind of a particular cultural framework? What suggestions that we make are implicit? What suggestions that we make are explicit, right? So when we think about implicit suggestions, I might think about, how do I set up the chairs in the room? And how does the way that I do that reflect the kind of power differential that I believe in, or that I believe should be there, for example? I had one participant who was really not feeling, so the couch is about 3 inches lower, not by design, than the chairs that the therapists usually sit in. And he just could not settle into his experience until at one point my co-therapist left the room, and he was the patient was getting up and he was quite restless. And he was talking a lot about power and how he kind of hates power and power is bullshit. He wasn't accusing us of, feeling that we were, or acting like we were in positions of power. But at some point, I don't actually know what came over me, but I asked him if he wanted to sit. I think, he was talking about the chairs. I asked him if he wanted to sit in the chair, so that he and I would both be sitting on chairs. And he was like, I don't know, maybe. And then he did. And that really unlocked something for him. He was so surprised by it, by the fact that it was even an option. It's not something that would ever have occurred to him. I don't think that it's something that would ever, now I think about it all the time. But then I wasn't thinking about it so much. And that really did kind of shape how I practice, and the ways in which I acknowledge now vocally up front, the ways in which this room, which I have no control over, is not set up to support the very things that, we're talking about with the participant, that are trying to mitigate the power differentials. In terms of explicit suggestions, we do that all the time, right? Anytime we vocally admire a participant's resilience, for example, we are suggesting, A, that they are resilient, and B, that resilience is good. So that's just, the first example that popped in my mind just now, but really be thinking about how, as a therapist, no matter what, stripe, you are always kind of priming your patients to be thinking about certain things, no matter how, again, no matter how non-directive you are. But even if you are in, whether you're talking about psychodynamic psychotherapy or even psychoanalysis, or talking about, transpersonal psychotherapy, something like that, that is always happening if you're tuned into it. So really start to notice that. I would advise you to do so. And to know, even when you think it's going to be explicit, and even when you feel like it's a quote unquote good thing, to be asking yourself, how well can I predict what message will be received, right? Because a lot of people might hear praise at accomplishing a goal as infantilizing, for example, or as a kind of narcissistic injury, because it is reminding them that they have goals, i.e. that they're not perfect, which then reminds them of this sort of framework of what it means to be perfect and all of those things. And so really, I would say the more suggestible a person is, the more crucial it is that you have honed and continue to be honing your skills as a psychotherapist, psychedelic or not. And then that's just in the therapeutic relationship. So in the relationship between the members of the triad. But Betty Eisner, who was a controversial but major pioneer in psychedelic work in the 60s, said set refers to the subject. Setting is the environment from the session. Okay, these are all things we've heard of. Matrix is the environment from which the subject comes, the environment surrounding the subject before and after the session, and the larger environment to which the subject returns. So that's matrix. It's the environment from which they come, the environment to which they return. I'll say that matrix is the Latin word for womb. Betty Eisner was doing a lot of her work with groups and in a residential setting. That is quite a matrix. And quite different from the highly individualistic model that we've used in, the field has used in almost all contemporary psychotherapy studies. Or psychotherapy, I mean that too, but psychedelic therapy studies. So this is another reason, this is something so important to be thinking about no matter what the, heritage of our patients, but particularly when we're thinking about failures of diversity in all of in all of these trials. And I would say it's probably still happening out there in in the real world as these are getting decriminalized and even legalized in some settings. So be thinking about not only honing your craft as a psychotherapist and always maintaining beginner's mind even as you do, but then also to be thinking about what's the matrix that supports psychedelic experiences. Doing psychedelics at Burning Man is very different from doing them again in a one-on-one room with a psychedelic therapist. And I'd say that for some people in certain contexts at Burning Man, that's a highly supportive environment. Not for all. And then thinking about how does each dimension of the matrix support or impede healing and growth and flourishing. So really trying to develop or to amplify your cultural awareness. And not just that, right? Not just to maintain awareness, but to be thinking about and feeling into what kind of a matrix are we co-creating? Not just as therapists, but as humans living in a world. Right? So the awareness that we're cultivating that might make us better therapists also makes us better humans. How are we living that out? Are we living that out? Are you somebody who is mindful and aware and compassionate in the consulting room, but when it comes to a person who bumps you on the street, you're cursing them out because you've had a bad day? What kind of a matrix are we co-creating even outside psychedelic therapy that then contributes to how supported and supportive those psychedelic experiences can be? So finally, this is my last slide. Recommendations for clinicians beyond all of the preaching that I've just done in the second half of this talk are to really adopt a harm reduction framework. And that's when discussing any substance use with patients, not just psychedelics or alcohol for that matter. Please stop with the psychedelic exceptionalism if that's your jam. It is really important to always to note and to document if someone comes to ask about psychedelics that you're not recommending illegal activity. If you're a prescriber, please learn the facts about common drug-drug interactions because again, you can't just say, I don't know, bye-bye. That's not safe either. When it comes to psilocybin for alcohol use disorder, and also when it comes to all of these psilocybin trials, please use caution when reading articles in both the press and in the primary literature. And please also urge caution when your patients come to ask you about it. We so often see study now that MDMA is sort of persona non grata. Psilocybin has come back to the fore and everybody's super excited again. And I've started to see those headlines that, they're the kind of headlines that lead to insane expectancy bias. And I would say ultimately could lead to unsafe use in many cases, but certainly interfere with the studies, with respect to the expectancy bias. So really, anytime you look at a paper, please carefully examine the inclusion and exclusion criteria. Just thinking, for example, about what I said about our trial, with the low, relatively, it was a relatively affluent population, for example. What does that mean for their matrix, right? What societies are they kind of moving around in, and how does that facilitate their integration of the experience? Notice how studies minimize the role of psychotherapy in their reports. Again, in our primary outcomes paper, that illustrated abstract said that the intervention was psilocybin versus Benadryl. And I will repeat, we had 31 hours of psychotherapy with 2 therapists over 12 weeks. So psilocybin versus Benadryl, that was not the intervention. I would urge you to note that, psychotropic medications are exclusionary in most of these clinical trials. And that's not going to be true for most people who are coming to you to ask about taking psychedelics. And so again, psychedelic exceptionalism would lead you to really kind of collude with their being immediately all on board with, okay, I'm going to stop everything and take it. And I would urge you to have more thoughtful conversations than that. I'm sure you're all outstanding clinicians, but I will say it anyway. And really resist the urge to think of psychedelics as a quick fix, and really resist the urge to think of them as a panacea. There is a real urge to do that, right? It's psychedelics for everything, psilocybin for anything. And that serves no one ultimately. These are much more subtle medications and experiences. And I think it's important to be aware of that. And again, humble in talking about it. And then finally, I would urge you to think about this question of what is your task, your unique task in the psychedelic space? And that's as a facilitator or therapist, also as a human, right? How are you working? How are all of us? How is even, the community of your cohort working to create a matrix that better supports individuals and patients in their psychedelic experiences? And so with that, I will say thank you to Michael Bogenschutz, my principal investigator. Gabby and Sam led 2 of the other analyses that I talked about in terms of the spiritual experiences that some folks had and the self-compassion. And these are the funding sources that led to the trial in the first place. And with that, I'm done.
Thank you, Kelly. First question. The Benadryl with 32 hours over 12 weeks was pretty good, right? 60 days down to 20 versus 60 to 4. And did the Benadryl group report mystical, transpersonal, etc. experiences?
So there were a couple. I was actually even surprised on so the way the MEQ score works is it's a combination. I don't love the scale, but you add up all of these different criteria that have been parsed out into different dimensions, and so you can, and it asks you in the last 8 hours at any point, have you had any of these experiences at all? And so you can see that some people who got the Benadryl, for example, will have had feelings of overwhelming compassion. And so it's a non-zero number, but they certainly weren't as high. That being said, like I said just a minute ago, I had a participant where I really didn't know. She really seemed, I think she's somebody that we would probably say is, particularly suggestible. I've never done any other kind of therapy with her, so I don't know. But but folks who are hypnotizable. And she had a really, really beautiful, profound experience that seemed like it could be a mild response to, I wouldn't even call it mild at this point because I've seen so many mild actual responses, but seemed at that point anyway, like it could be. So that being said, it depends on how you kind of wrangle the numbers, but actually on our trial, it was the case. We found that the mystical experience was not predictive of the outcomes. So though your question is interesting, and though actually that particular participant did quite well, our findings did not support the idea that, of spiritus contra spiritum. And so, so that's interesting. And that was kind of surprising.
Why was the average household income so high for participants in the study?
Great question. If you want, I don't know. I would guess that in general, so midway through the study is when Michael Pollan's book came out. And it was a real boon for recruitment. However, I think it really ended up biasing the sample. It meant, in terms of it being a boon for recruitment, it meant that we didn't have to spend money on recruitment because people read the book, saw Anderson Cooper talking about it. That was when, sort of, it's hard to imagine now, but that was when the headlines started, getting up and running. And I think that those people who read the book and trust Anderson Cooper hail from a sort of more white, educated, affluent demographic that I think ultimately did a disservice to diversity and was behind the increase. I think also you have to have money to be able to take time off work, and that's something that you have to have money to, to make that work. And if you have kids, you have to have money to cover childcare. So lost income and childcare on days that you're taking off, I think also kind of funnel more affluent people into these studies and really aren't appropriately addressed. Like when I talk about recruitment costing money, it doesn't just cost money. It costs, there's a certain cost of awareness that has to happen, and thinking about all of the different ways in which it's not just about handing somebody $50 at the end of a long day. It's, how did we contribute to the matrix that puts them in a position to need a hell of a lot more than $50 in terms of the support to make it an acceptable thing for them to be doing.
Is there any data on psilocybin versus naltrexone for those whose AUD isn't rooted in a desire to self-medicate psychospiritual woundedness?
No data. Love the question. One of the studies that we're going to do is around, has to do with psilocybin and naltrexone, and whether psilocybin experiences can increase someone's adherence with naltrexone. Naltrexone's a great drug. Again, stop with the psychedelic exceptionalism if it's anybody's sort of jam. Alcohol use disorder is awful. And in some people it's really debilitating in some people's lives. And naltrexone is life-saving for some. So great question. No data. I wish, I will probably say that for another 9 minutes. But hopefully in the next 10 years, we'll have more answers.
What type of schedule have you found to be most beneficial for psychedelic-assisted psychotherapy? A therapy session per every medicine session? And how far after the medicine sessions are you doing therapy sessions? And then how far out are medicine sessions from each other?
So in this large trial, for example, much like the like MAPS trials, they were spaced out. So this one was two dosing sessions, and they were a month apart, and they had so there were 4 prep sessions beforehand, which I think could technically be condensed to like 2 or 3. And then it was, I don't remember if it was 2 or let's just 3. Let's see. um, oh, it was 4 sessions in between each of those two. So it was quite a lot. That's more. So the MAPS trials, this is a different drug, obviously, but the MAPS trials had 3 in between each of the kind of 3 dosing sessions, also a month apart. I'm trying to think. I'm on a couple of trials right now where, well, no, because that one's just one. I'm on a couple right now that are just one dosing session. I have to say, I don't recommend that. So I've worked now on trials, besides the MDMA for PTSD, just with psilocybin, cancer-associated anxiety and distress, major depressive disorder, smoking cessation, alcohol use disorder. I feel like there's another or 2. I don't remember. Anyway, a couple of those have had one dosing, and I think the one dosing, the one and done kind of situation is a total fantasy. I think that, even with the 2 dosing sessions, like we had some impressive results out, many months. That being said, I believe I could be wrong. I have a sense that some of those people reduced their drinking and continued to keep it reduced because they didn't want to disappoint things. Not that we put anything in their minds, but they kept seeing the headlines. They kept, being told that psilocybin was the be all and end all. And they kept wanting other people to be able to have what was for them a useful experience, that they did more in terms of reducing their drinking than they might otherwise have done. And again, that is where sort of the low diversity comes in. If there are people who are like, if we got a higher concentration of people pleasers, through no explicit fault of our own, then that is going to affect your outcomes. Yeah, I don't remember what I was talking about, but yeah, I really don't. Sorry, guys.
I was scheduling and space between sessions and.
Oh, sorry. Yes. So this study was 2 sessions a month apart, with 4 90-minute therapy sessions. No, 2 1-hour and 2 90-minute therapy sessions between each of the 2, and then also at the end. How much do I think is ideal? I think the more therapy, the better for almost everybody, honestly. I think that one therapy session per dosing would absolutely not be enough for any kind of meaningful long-term change, period. I think that's true whether you're going on to another dosing or not. Like if they're just sort of finishing, I think it's a total fantasy. I'm not here to preach against sort of people exploring their own consciousness, but if they're really looking for some kind of meaningful clinical change, like for the long term, then I don't see that happening. I have never seen that happen, and that's even with my highly affluent, rarefied, population of people pleasers. So yeah, and the reason that I say that I haven't seen it happen is that I actually did have a number of participants. So after the randomized controlled trial portion of the study, there was an open label portion that anybody could participate in. So if they got placebo, in the first part, they ended up getting 1 dose plus therapy of the psilocybin in the open label section. The people who had gotten placebo or psilocybin beforehand ended up getting like a 3rd session. And everyone who got the 3rd session who had gotten psilocybin said, I really feel like I needed all 3. Like nobody said to me anyway, I didn't see every participant, but nobody said to me, could have done without that last one. It was often the case that it was sort of seal the deal. And similarly, actually, for the MDMA trial, participants would often say that that having a set number was useful, because it sort of like kind of prompted them to do more work as they went. But having the set number also meant that they didn't have to like dive into the first one as though, this was their only chance to do any kind of meaningful psychedelic work. And so it kind of eased them in, and still like there was a limit on it. But definitely 1 session of integration is absolutely not enough. Some people will need significantly more. Everybody needs more. Some people will need significantly more. And I would say that that's true no matter what your clinical indication. Roz Watts has talked about that with depression. I've certainly seen that a lot with depression. It's not uncommon for participants to reach out to me like 6 months later, say, and ask if they can be in touch with other participants or if I know psychedelic minded therapists, et cetera, et cetera. Even if they seemed to be doing fine at the end of the study. Past depression, TBD with the smoking, it's still early days, but yeah.
Has the Benadryl only study over 32 weeks been repeated, resulting in 40 days or fewer drinking days?
I just want to make sure that we're not calling it Benadryl only because it was Benadryl plus psychotherapy, which is really good. No, it hasn't been replicated. No, there's sort of no reason that anybody would want to fund that. But really, none of us, at least who were working on this study, think that Benadryl is a cure for alcohol use disorder. If you look at the slope on our primary outcomes, the slope from baseline to just before, to the first point after that is higher than the slope, from psilocybin. And I don't think that that's, just their excited anticipation of Benadryl or the possibility of Benadryl. Expectancy definitely plays a role, but it didn't bounce right back up. So it wasn't all expectancy for psilocybin. They stay pretty stable. And yeah, there too, I always wonder whether the fact that they're going to get like there's going to be an open label session, like I wonder if that affects outcomes. They sort of know, okay, I don't have to be totally bummed out because it's coming. I can see what I can do here and then it'll be there. Most of my patients who were placebo first and then got the session said to me, you know what, this was actually the right time. I'm actually I wouldn't say I'm glad that I got placebo, but I'm kind of glad because this was the right time for me. And so that's always interesting. But no, Benadryl hasn't been replicated. People only really conduct studies around drugs that they think are going to make them money, and it's been around a long time. But certainly interesting findings. But if you know someone with alcohol use disorder, go ahead and give them, see if they're not allergic, invite them to have 100 milligrams of Benadryl and see what happens.
All right, well, that brings us back to the top of the hour. So that's all the time we'll have for questions. But I will close out with one comment that was dropped into the Q&A here, which says, just want to say thank you for the self-aware and open-minded, open-hearted presentation, willingness to question the protocols and the social milieu in which these have occurred. So
Aww.
Thank you, Kelly, and thank you so much for taking the time to join us today.
Thank you all for your thoughtful presence. Be well.